All right. Well, again, thank you all so much for joining this session. We'll be talking about health literacy and digital literacy and how do we make telehealth a positive experience for all. My name is Kim Mayo. I am a senior specialist here at the National Rural Health Resource Center. And so I'd just like to take a moment to orient you to the virtual format and then introduce our speakers. So all sessions are being recorded and the recordings will be available in the attendee hub after the summit is complete. Participant microphones are muted. We do, however, encourage you to ask questions and interact with our speakers. And if you have any questions during the session, we can utilize that chat box feature, or feel free just to unmute. I'll be monitoring the chat box during the presentation and will communicate the questions to the speakers during the Q&A. If you need access to the closed captioning, please click on the closed captioning button at the bottom of your screen. As a reminder, the American College of Healthcare Executive, or ACHE, credits are available for each session. There is a notification card right in the attendee hub where at the link to the document that needs to be completed if you would like to receive those credits. I'll now introduce our speakers in our session. So the topic for this session is health equity and digital literacy. And in this session, we will explore the advent of telehealth and how innovation created has exacerbated an already growing problem in digital literacy. In this session, we will discuss how HRSA is working to remove barriers and increase health equity. Examples of real-world cases of how collaborating with partners to bridge those gaps will be discussed. The speakers will delve into broadband and connectivity initiatives from the FCC and HRSA, the landscape of health equity and how the social determinants of health are affecting the care delivery model, and examples of how rural health networks are using collaboratives to reduce disparities and increase digital literacy. So before I introduce our speakers, I would like to remind you that we have some pre-polling questions that will be launched, and you'll find these questions. I'll pop up on your screen. While you're filling out those polls, I will introduce to this session's speakers. We have Michael McNeely, and he is the Director of the Telehealth Innovation and Services Division within the Office of Advancement of Telehealth, Health Resources and Services Administration. Mike is a certified professional of health information and management systems and received his Bachelor's of Science in Biology and Physiology, as well as his Master's of Public Health and Health Services Management from the University of Kentucky. Additionally, he received a Master's in Business Administration from Thomas More College. And Michelle Hager has over 20 years experience in healthcare IT and is the managing partner at Blue Cirrus Consulting. For the past 10 years, she has dedicated her efforts to development of telehealth strategies for healthcare organizations, including Intermountain Healthcare, Adventist Health, Greenville Health Systems, and Palmetto Health. She has worked diligently through HIMSS to educate the industry and the public on healthcare IT public policy and future IT strategic dreams, including telehealth policy. All right, now we'll get that poll closed and we'll turn it over to Mike to get us started.
Thanks, Kim. Good afternoon. I'd like to thank you for joining me and a bit Michelle in our discussion of health equity and digital literacy. I'm the Director of the Telehealth Innovation Service Division, as Kim pointed out, within the Office for the Advancement of Telehealth, or as we affectionately call it, OAT. It wouldn't be government without an acronym, to be honest. Next slide, please. Today we'll be covering a number of aspects around our topic, but I'd like to start off with some clarification on what we consider telehealth, who we are, more importantly, what our parent organization is doing, HHS, relating to health equity and digital literacy, and closing with what is OAT doing. Next slide, please. What's telehealth? What you see here is the definition used by our office. The key here is that it's the use of electronic information and telehealth technologies to support care, education, public health, and health administrations. It's delivered through a variety of modalities. Additionally, the benefits of telehealth include provider benefits, which improvements in workforce development, improves care delivery, serves more patients, lowers no-show rates for patients, increases access to care, reduces travel, lessens wait times to receive services, and for payers, it reduces the cost for transport, enhances outcomes, and lowers costs due to more timely care. With that, let's talk about next slide, please. So what do we do? For starters, we serve as the experts of telehealth for HHS and coordinate across government to improve access and strive for better outcomes for clinicians and patients alike. We also promote telehealth technologies. Lastly, but by no means least, we provide funding for grants and cooperative agreements to provide direct services for research and TA for implementation of telehealth programs. Next slide. This slide shows the continuum of OAK. It was first established in 1988 and as part of the Federal Office of Rural Health Policy. We became established as an office in 2002. From there, we moved around HRSA until we returned to FRHP. Last year, OAK was elevated out of FRHP as a standalone office. Throughout that time, OAK established working groups across government with the inception of FedTel in 1995, and in 2017, HRSA established its own telehealth work group, where we have been able to identify the total number of touch points telehealth has with HRSA's grants. As part of the elevation of OAK, which is separate, we went through this longer process, but it was about a 2-year endeavor. But we have become responsible for HHS review of policy and the system and all things telehealth for the department. Next slide, please. This slide just shows our recent distribution of grants. This is as of fiscal year 21. As you can see, we are in many of the states. Our reach does also include the territories. We're not in every state, but we are. We're making our way there. So we're kind of limited by our budget, but as we do, we're trying to expand out. Next slide, please. This slide demonstrates our approach to grants. The main takeaways from this are that we use innovation centers to fuel pilot programs. Those pilot programs are then refined and are used to create an initial evidence base. From there, we bring the pilots to scale to create a broader reach and impact. Every step is deliberate. So it goes from the pilots, it goes to building the evidence base, and then it ends up in going into a broader program in general. So we use each step, we learn from each step, and we refine. Next slide, please. So this brings us to our topic. I want to outline the administration priorities that align with our topic. For health equity, we're looking at ways to address racial and ethnic minority disparities. We're also looking at the disparity in rural, and we're trying this by trying to address disability accessibility also. These are addressed through programs and directives that focus on telehealth and complemented by engaging and training the healthcare workforce. Additionally, as part of the White House Equity Plan, numerous departments and agencies have been tasked with parts of working on the equity plan itself. So HHS, for example, will advance health equity for underserved communities by providing targeted outreach to communities of color to encourage enrollment in free and low-cost healthcare as well. HHS will also respond to the national maternal mortality crisis by addressing the increased pregnancy and postpartum morbidity and mortality among Blacks and American Indian and Alaska Native pregnant and childbearing people. The Department of Veterans Affairs, on the other hand, will advance health equity for underserved veterans by addressing the social and economic determinants of health for underserved veterans, including veterans of color and veterans who live in rural communities where care is harder to access. And the Department of Agriculture will expand equitable access to nutrition assistance programs by improving access to the Women's, Infants, and Children Nutrition Assistance Program. Next slide, please. With that, let's delve a little deeper into what HHS HHS is doing. HHS has identified the following strategic goal: protect and strengthen equitable access to high quality and affordable healthcare. This goal is supports efforts to increase choice, affordability, and enrollment in high quality healthcare coverage, reducing costs, improving quality of healthcare services, and ensuring access to safe medical devices and drugs, expanding equitable access to comprehensive, community-based, innovative, and culturally competent healthcare services while addressing social determinants of health, driving the integration of behavioral health into the healthcare system to strengthen and expand access to mental health and substance use disorder treatment and recovery service for individuals and families. And then lastly, bolstering the health workforce to ensure delivery of quality services and care. There's a second goal, and that was identified, focusing on strengthening social well-being, equity, and economic resilience. This will be done through providing effective and innovative pathways leading to equitable economic success for all individuals and families, strengthening early childhood development and expand opportunities to help children and youth thrive equitably within their families and communities, expanding access to high quality services and resources for older adults and people with disabilities and their caregivers to support increased independence and quality of life. And then lastly, increasing safeguards to empower families and communities to prevent and respond to neglect, abuse, and violence while supporting those who have experienced trauma or violence. Additionally, HHS has an equity action plan, which is at the top of this slide, that I'd like to hit on also. And it's being implemented by focusing on non-discrimination in HHS through protecting civil rights and ensuring language access, working to increase opportunity to HHS contracting for small disadvantaged businesses and historically underutilized business-owned small businesses, using our grants to support incorporating equity considerations into the notice of funding opportunities, concentrating on capacity building to help incorporate equity into HHS policy and program actions, including by conducting equity assessments and disparity impact strategies, and then prioritizing maternal mortality action addresses that the increased pregnancy and postpartum morbidity and mortality among Black and American Indian, Alaska Native pregnant and childbearing people by focusing on working with states to extend health insurance coverage in Medicaid and the Children's Health Insurance Program for all enrollees who give birth and developing innovative ways to improve postpartum care. Next slide, please. Some of the actions HHS has utilized include conducting equity assessments. So pilots are done to examine programs and policies related to administering grants, contracting, and postpartum care and benefit enrollment. The goal of these pilots were to work out the bugs to make their findings more scalable. Also, the Office of Climate Change and Health Equity was established. This office acts as a hub for climate change and health policy programming and analysis. It's new to HHS and kind of acts as a one-stop shop, both looking at the climate change, but also at the impacts of, that has on health policy. Next slide, please. Within HHS, the CDC and the Office of Minority Health have partnered to develop the Minority Health Social Vulnerability Index. There you go. Which is an extension of the CDC ASCAR Social Vulnerability Index, which is a database that helps emergency response planners and public health officials identify, map, and plan support for communities that will most likely need support before, during, and after a public health emergency. HHS also increased engagement with those impacted by HHS policies and programming, with a number of agencies and offices working to combat disparities and inequities. Next slide, please. HHS also has the national plan to improve health literacy with 7 goals. I won't read these to you, but in general, this has been a focus that goes throughout HHS itself and then has been distributed down to the individual agencies that make up HHS. So it's important to understand how these relate back to how we develop policy, how we develop programs, and how we are looking at ways to advance both health equity and digital literacy in itself. Next slide, please. Additionally, on the telehealth side, HHS developed telehealth.hhs.gov. It's now a go-to site for telehealth information for providers and patients. Since its inception in the fall of 2020 through April of 2022, there have been a total of about 1.8 million users. And just as a shameless plug, we actually take care of this for HHS. We are HHS in this sense. So it's a contract that's administered through OAT. Next slide, please. On this site, we have a number of toolkits created to ensure equal access to quality healthcare. Just some examples of what can be found on the site include toolkits on improving access, telehealth and for LGBTQ plus patients, and telehealth in older patients. This site has regular updates, and we are actively creating new resources. We have our own listserv as it relates to this, to the Office for Advancement in Health, but as we push out our own newsletter, which comes out roughly bi-monthly, there is usually new resource that's created. Another set was put out today specifically addressing cancer care, but there's a number of resources that are out there. Next slide, please. So HRSA's telehealth initiative. So we'll look at HRSA in this case now, in the broader sense, in that HRSA's telehealth initiative serves as a resource for underserved communities and provides recommendations to improve access to healthcare services. The initiative focuses on clinical telehealth services, telementoring and DTT, distance learning, research and evaluation, and telehealth business strategy. And then last but by no means least, broadband resources. Next slide. So let's talk about the impact of telehealth across HRSA in general. In fiscal year 2020, HRSA awarded more than $1 billion for telehealth activities. And HRSA has had approximately 3,850 awards that included telehealth during that fiscal year. This is approximately 37% of HRSA awards. This number has trended up over time. We're currently doing the 21 inventory, so I hope to be able to update this information the next time I give one. But that could be available a little bit later this year. Telehealth also uses supported by HRSA included workforce training, direct clinical services, distance learning, clinical support, infrastructure development, technical assistance, administrative support, and research and reports. Over 550, which is about 14% of the awards, included distance learning, which is Project Echo or Echo-like. And Telehealth addressed health equity in HRSA through awards made to rural communities, underserved communities, low-income populations, children, family caregivers, women, school-based populations, LGBTQ plus, homeless populations, and tribal communities. Next slide, please. So I've talked about the administration and HRSA's priorities around telehealth and equity, but I would be remiss if I didn't delve a little deeper into the implication of broadband and the push towards health equity and digital literacy. Broadband can be considered an equalizer when looking at healthcare delivery. Its presence can directly impact economic stability, educational access, and health status and quality of life. Broadband isn't everywhere, and there's a lot of places that take access to the internet for granted. Unfortunately, there are deserts out there, both literal and metaphorical, as it relates to broadband. Because of this, as part of the Infrastructure Act, $65 billion in funding was created to address equity. $42.45 billion focused on closing the access gap for underserved and unserved parts of the country. $2.7 billion through 3 programs for promoting digital equity, digital inclusion, and building capacity for broadband adoption. $2 billion focused on supporting tribal access. This one resulted in NTIA creating a new office that is specifically focused on tribal affairs and tribal broadband issues. About $1 billion for middle mile broadband infrastructure to reduce the cost of serving unserved and underserved areas. Next slide, please. And this is where I talk about what we're doing within OAT itself. Through the program OAT supports, our grantees and award recipients have made major investments in health equity and accessibility resources. The list here is just a sampling of the materials and the resources that have been developed for public use. Our work ranges from introducing Telehealth 101 resources to the development of multilingual materials to applying culturally sensitive Project Echo engagements. Next slide. Some of the ways we are able to work on these investments is by working with our telehealth resource centers as part of their work plans to focus on issues relevant to the regions and the broader U.S. Currently, we have 12 regional TRCs and 2 national ones. The national TRCs focus on policy and technology, respectively. What's important to note is the TRCs are public resources. They're there to provide technical assistance to providers and patients and private and nonprofit alike. Each year they add to their inventory of tools, so it's always good to check them out. As you look at them in the various regions, there are these opportunities to create resources. Like the South Central TRC has materials that are actually designed. They're multilingual material that is focused on like Marshallese. There are our Southwest, there are Navajo translation. And there are many of our TRCs have regionally specific resources that deal with the populations there. Next slide, please. The Telehealth Technology Enabled Learning Program, TTELP, is a program that currently funds 9 award recipients and is a 5-year program. We're about to start the 2nd year. But what's important about this program is that it connects academic medical centers with rural providers. The program uses ECHO and ECHO-like learning collaboratives to train and support personnel providing care to patients. Currently, the major focus, there are a couple of areas that they were looking at, from behavioral health to long COVID monitoring, but it's the impact that's happening from the academic centers and the interactions on the rural side, and then trying to create interventions that are appropriate for rural distribution. Next slide, please. And then the Telehealth Broadband Pilot Program is a first of its kind within HHS. The goal is to assess the broadband capacity available to rural healthcare providers. We're using the program to understand where the gaps are and what the needs are for rural providers. The program was initiated before the Infrastructure Act passed, so it predates that $65 billion. So it's evolved a bit. We're working in 25 counties in 4 states, in Texas, West Virginia, Michigan, and Alaska. And we're analyzing the broadband availability of providers and consumers. So we're also trying to map our findings, and we hope to share this data with FCC as they roll out their broadband programs. So we know that they're going to have some gaps based off of the way that certain ways they are collecting the information. So we're hoping to use our findings, which will be a little more localized, to give them another view of the counties that they're creating for their particular broadband map. The other thing that's going to come out of that program is that we're hoping to take the lessons we learned and the understanding of the gaps that come from it and find a way to scale it up at some point. And so we want to try to address broadband access, but also expand telehealth access through that. And then next slide, please. And this is just a slide of resources. that are currently available. Aforementioned telehealth.hhs.gov, and then the telehealth resource centers have a consortium. So it's a one-stop shop where you can actually look at all their materials. And with that, next slide. And for more information or HRSA information, or you can reach out to me. With that, I'm going to hand off to Michelle so that she can.
Yes, thank you so much, Mike. Yeah, thank you so much, Mike. I will stop sharing now and let Michelle pull her slides up. If you all do have any questions for Mike or for Michelle as Michelle speaks, feel free just to drop those in that chat. We'll be happy to entertain those. So, Michelle, whenever you're ready.
Thank you so much, Kim. Mike, that was great. And it's a great dovetail into some of the things that I'm going to talk about as well. And interestingly enough, your video as well was just a great tie-in also. So hopefully this will be helpful information that you can take some nuggets away and use them in your day-to-day practices. And if there are any questions, of course, myself and I'm sure Mike will be available as well. And some information you'll see is crossover. So you know it's important because we both spoke about it. Telehealth in the rural areas, of course, is extremely important. We know that only 11% of physicians practice in rural areas, despite almost 20% of the population being in the rural area. So some of the data around rural areas may not be surprising to any of you. However, what we find is that telehealth will help improve the monitoring and timeliness of communications between providers, which of course increases the level of service that they can provide and therefore increases capacity. We know that fewer patients will need to be transferred from rural hospitals, which of course helps organizations and health systems be able to keep those patients and therefore the funding associated with them. I live in South Carolina, we're 90% rural, and we found several hospitals that have closed over the last several years, and that is due to a lot of different factors, not the least of which is the fact that patients are transferring that leakages out of individual health systems and hospitals to urban areas. So we have to stop that. We have to increase the acuity level that individual clinics and hospitals can care for. And telehealth will also allow smaller hospitals to provide that quality of care, as we just talked about, minimizing the need for travel for patients for specialty and subspecialty care. It's really important. That's a patient satisfier. We know that that's a patient satisfier. Data shows that day to day. The patients that are in rural areas are older, sicker, and poorer. That means that it's even more difficult to get to them with healthcare, and they tend to be a little bit more skeptical around healthcare as well. So we have to find different ways to access them. Telehealth is a great way to do that, but of course that also includes some skepticism as well around the technology and some of the challenges that we've seen around accessing those patients, particularly in the broadband space. And in this particular study, all of my slides have references on them, so you'll have access to them. You can go back and look and see them updated. But this is a good one that the Commonwealth funded some time ago, just a few years ago, probably worse now post-COVID. If you look at any of the data demographics associated with access to care, the demographics inside of a rural area, health status, behaviors, and particularly the isolation, rural health has the highest numbers associated with those, and highest not always in the best way. Isolation, of course, has to do with the broadband access, but also it has a factor in mental health of the patients that are in, or the people that are in the communities, of rural communities. And I used a quote from Alan Morgan I thought was a great one from this study, but it is a unique healthcare delivery environment. As he said, we have elderly population, sicker population, low income population, and yet have the fewest options available. So we have to do more with less, and we really have a perfect storm, as Alan Morgan said in this particular interview. So, really, how are we going to address some of these issues? This is a data map that I saw around mental health providers that exist in a variety of, this is county-based. Our company has done several studies in the state of Florida and the state of Virginia, for example, and others, where we looked at mental health providers and how accessible they are, in fact, to the patients in those areas. In the Appalachian area, for example, looking at the mental health providers, you would look at a county level, you might say, well, there are plenty of providers in that area. Well, in fact, they're only practicing in the cities or in those local towns, not in Appalachia. So it's very difficult for someone to get from Appalachia to, say, Richmond, Virginia, because that's a long way away, and they may not have transportation. As Mike mentioned, transportation is a big concern. Same thing with one of our studies we did in the south of Florida in the agricultural area. We know that Palm Beach County, for example, covers a wide swath in the state of Florida, down in southern Florida. However, in an area where there's heavy agricultural on the western side of that county, there's virtually a desert of mental health providers. So they're all practicing along the beach line and in those urban areas. It doesn't really help the patients that are in. So we have to do something to increase that capacity. We have to move the specialties around. And I think it's difficult when you're doing some analysis. I would encourage you to look at where those individual providers are located, because sometimes maps like these can be misleading to show, oh, we actually have a really dark green in our county. Well, they may not actually be practicing in the areas that you need them to be practicing in geographically. And I would suggest to you, based on our experience, that traditional healthcare partnerships, and this was in the video as well, typically all of these organizations would work together to help care for the patients in the population, which is great. Again, these are more traditional healthcare partnerships. What we find in rural areas is these are helpful, but we need to have more non-traditional partnerships. So we found in several of the projects that we've done that including in the state of Florida, in the state of South Carolina, for example, we have the South Carolina Telehealth Alliance. It's a very well-funded organization, but it's a good model to look at the types of organizations that you should include as part of a group. So including those more traditional healthcare partnerships, but then also look at your radio and TV stations. These are great ways for you to be able to communicate to your population. What is telehealth? We found that not only do we see challenges with patients accepting technology, but the digital literacy is very low. So how do we look at utilizing non-traditional partners like radio and television to educate, and public television, for example, to educate the public on telehealth and the use of technology to be able to care for themselves in a better way. Also think about things like your grocery stores. These are the most common grocery stores in each state, Dollar General, these areas where people tend to congregate to get food, to be dropped off for a job, for example. Maybe everyone gets picked up in one location. We found that looking at these non-traditional partnerships and finding places for us to put just an iPad or a kiosk, some kind of a spot for them to access telehealth services. These are also good care transition spots. We found with some of our other clients that where they have challenges with homeless populations, any of these care transition spots where folks are going to get, say, for example, a food banks, or going for other resources, or are there for the homeless population. If there's a shelter that they're attending as well, it's a great place to put some kind of a kiosk, so that there may be a case manager that goes to those locations, and they can actually connect back to the health system. So if that patient was in the emergency room, now they're in, say, they're at the Dollar General picking up some food that they might be able to get from a food bank that might be there, or at the grocery store that's local to them, or some other spot, they can access that care, and the case managers can help with that care transition because they likely haven't gotten their prescriptions. Walgreens and CVS are doing lots of different types of services now, and partnering with them. They actually are very interested in partnering with rural organizations right now, and of course your local Department of Health. One that's not here that I think is interesting, and bringing those groups together in some kind of a governance, along with your mayors of your town, to talk about how do we better move capacity across our organization. Good example is in Florida, where we saw that we had capacity in the mental health space, but other organizations were not aware of that. So our study identified the capacity but that was not available to these other organizations, or they were not aware of them. So that brought that to the top. We brought that to their governance committee so other people could be aware of it, and we could take advantage of that additional capacity, particularly in the mental health space. So bringing these non-traditional type of organizations together to help you to better care for your patients and your populations, not always looking to those traditional types of spaces where we would typically see healthcare and population management happening. Believe it or not, these other organizations are very interested in it. And we find that the mayors of those towns, as I mentioned, are very helpful. But we need to make sure as we move towards innovation, as we see technology being utilized more and more, that we don't create a digital divide. And we know that that's happening. It kind of got exploded in COVID. Now everyone was doing some kind of digital intervention, some kind of digital healthcare providing, and we now see this exacerbation. It's a good thing because we might not have seen this particular issue right away. We see this exacerbation of a digital divide. So not only patients that don't have technology, but that just don't know how to utilize it for that purpose. So we know that there are centers that you can utilize these services, particularly for seniors. For example, there's a lot of partnerships that are happening with centers for aging who are helping educate seniors on how to utilize their devices, how to set them up, and how to get them to where they need to be. So these are kind of interesting programs because they are teaching them how to use devices for not healthcare. So they might say, let's learn how to do Pinterest. You want to get a recipe? Let's teach you how to get to Pinterest and get that special recipe that you want for your grandchild's, birthday. Or how about if we teach you how to do a FaceTime? Or let me show you how you can do, Messenger setup in Facebook. All these other things that help them connect to areas that they want to be connected to, and then they can utilize those skills to access healthcare, because no one necessarily wants to have, let's contact our doctor on a day-to-day basis, right? We don't want to do that, but we do want to contact our family. We do want to find social services that can help us in activities that we want to do on a regular basis. So the Center for Aging has been a good partner in that space. In addition, we know that the National Digital Inclusion Alliance, this is another area where you can utilize their services to get practitioner support on telehealth. They can help with policy and advocacy, increase awareness on digital services, as well as other public resources as well, to be able to understand how to use technology and other digital tools. So there's lots of different options there in the National Digital Inclusion Alliance. As Mike mentioned, the TRCs are a big resource. And as I said, this is an important one because I've mentioned it as well. So the Center for Connected Health Policy, for those of you that are doing this day in and day out, is a great space to be able to find what's happening, what's the latest on reimbursement, what's the latest on public policy changes and policy changes related to scope of practice, et cetera. They keep a very close eye on it and do a great job there. But your individual regions are a great source of information and assistance. There are also some free online educational tools. So for digital literacy, for example, there's digitalliteracy.gov. Lots of links here that you can take a look at. There's also the National Collaborative for Digital Equity. It's actually a UK-based company, but they do have some downloadable guides that are really great. And the same with Learn My Way. So they've been doing some telehealth across the pond, and they are able to, you're able to download and utilize their digital literacy tools as well, and maybe make them your own. So there are also some public and low-cost resources for patients. What we find is sometimes in populations, patients may not have access to the right technology. They might not actually have enough data to be able to support a telehealth visit. And so these types of programs, and I'll show you in the next couple slides here, help patients connect to devices and wireless internet. If you, for example, are eligible for SNAP or WIC or other types of public housing, this is a great program for those patients. This is a good listing to just kind of keep by your desk. If you're dealing with patients on a day-to-day basis, you can look at this, and see, are there programs that we might be able to access? And then you can see wireless hotspots as well. Sometimes they start as low as $20 a month, which I know $20 is $20, but that's better than $100 on Verizon's regular, services or whatever. FCC funding, I think Mike talked a little bit about this. This is from the Rural Healthcare Program. I'm sure many of you are aware of this one as well. And then one of the others that I think is a great one is the Connect Home. I think this program has changed names a couple of times, but a public-private collaboration with HUD focused on digital education and helping school-age kids be able to access digital tools and community-based programs. So this is access, of course, for free and low-cost broadband access devices and digital literacy training. So another area for you to take a look at and see if that works for your community. I actually think this is a really interesting. We used to just do Starlink and say, well, Starlink's a great option. I love that the Office of Telehealth Advancement is Advancement of Telehealth, is doing a study, and we're seeing a more accurate study of where people actually have broadband, because that's huge. We know that across the street they may say, oh, we have plenty of broadband in this county, but you go right across the street and there's no one that has access to that. And I know that there's more and more that's being implemented today that is connected up to other utilities like electric bill, so that's all part of that. But Starlink and actually now DRCHSD are both doing this satellite broadband connectivity. So we know that Starlink's kind of a little bit spotty, for example, may not be in everybody's area, although they're expanding and putting satellites up all the time. Now we see DRCHSD getting into that. So AT&T is putting together their satellite-based broadband enabled connectivity. They're not too happy. Starlink's not too happy with that, I understand, but I think that's great for all of us. More competition is a good thing. Will lower the cost. So could be a game changer for some of your folks in your populations. And again, more information is better. Obviously, FirstNet is important. What we find is things like expanding capacity, for example, around EMS services. When we see community-based telemedicine being utilized, which is a large differentiator for some areas, particularly where we have patients that are coming to the emergency room on a regular basis, and we've identified them as a potential that we might be able to keep at home with minimal service provider. So EMS, paramedic, or even MIH, be able to go over there, see a patient, maybe even be able to provide them clinical care. I know some folks are doing with EMS are doing even LASIKs in the field, just to be able to better care for these patients before they get to the emergency room, so they're not there on a regular basis. And I know that's hard to do, and particularly in rural areas, offices are closed at different times. And so people tend to kind of focus in their culture, trying to change the kinds of focuses on let's go to the emergency room. But these are other ways that organizations can expand their existing clinical footprint and utilize some clinicians that they may have overlooked in the past. We also have free resources on our website. We do webinars and radio shows and educational talks on all sorts of issues. If you have a topic that you want us to cover, whether that's reimbursement, you can see this particular screenshot had included provider compliance, and also a session on virtual first. Will payers start to move forward with virtual first? Will they say you have to do a virtual visit first before you go to a brick and mortar type of location. Who knows what that will be, but if you have a topic, we will be happy to cover it. We're always looking for new topics and want to cover things that people want to be aware of. So I just circled that. It's kind of in our knowledge dummy. You can look at that. It's free resources in there, and you can go back as many as we've done over the years. Always want to thank our healthcare heroes that are on this call. I know all of you are on the front lines every single day, taking care of these patients, making sure that their healthcare needs in the community is better off. I really loved what you saw in the video with those patients and organizations there from, I think it was Pickneyville. I hope I got that right. So that was a great program. And I think that it encompasses what you do every single day. And I think it's even more so in the rural area than urban. You're every day taking care of those patients, regardless of what's happening around you and the stressors that you're feeling. So thank you for your work. If there are any questions around anything that we talked about today, or you just want to ask additional, ask for additional information or any of the links that I provided, please feel free to email me or call me at either of those contact details. You can also follow us on Facebook, LinkedIn, and Twitter, and we share information on a regular basis.
Thank you so much, Michelle and Mike. What great information. Very appreciative of all that information. And we would love to entertain, we do have a few minutes. We would love to entertain any questions, any comments, that while you've got these subject matter experts here with us, we can take advantage of their knowledge and pick their brains.
Yeah, I would definitely encourage the rural areas to create some collaboratives together, having those disparate types of organizations working together, not the traditional, as I mentioned. And I think Mike mentioned that, and your video mentioned that. That's huge. There's lots of pockets that you can take advantage of.
Yeah, and I'll add to that is that a lot of things are network oriented when it comes to grant opportunities and funding opportunities in general. So even non-traditional networks are one of those things that are being looked at as things are put out there. They just need to, be able to work together and have a general focus.
Yeah, so important, so valuable. Absolutely, we've seen that message already in the summit as we've kicked off our keynote speaker. That was one of the main points there. And I do just want to reference the videos that have been playing, that you all know that those videos are available on the Attendee Hub, as well as on our website at the center. So we'll be highlighting those throughout the rest of the summit. And we are greatly appreciative to be able to share those success stories. And that's exactly what they are. So we are grateful to be able to play those. So if anytime you miss one or you come in the middle of one, they are available there. You can watch them at your leisure as well. All right, any last questions, any comments? You all covered it well.
Thank you, Kim. It was a pleasure to speak with you, Mike.
Oh, yes. Yes, we thank you both. And Caroline has linked those videos in the chat as well. So if you want to grab that link, then you'll have direct access to any of those videos that you'd like to watch. Well, I would like to extend just a big thank you to, of course, our speakers, but also our audience, everybody that was able to join us today. Up next is our lunch break. So we'll reconvene at the concurrent session starting at 1 p.m. Central Time. And then 2 concurrent sessions coming up at 1 p.m. are managing stress before it manages you, and health equity and the correlation with value-based care. So at that time, as you step away for lunch, if you do lose connection, please note that you can always return to the Attendee Hub and to access the live sessions at any time. So we thank you, everyone. We hope that you have a great lunch, and we'll see you for the next session.